My name's Kay Dickerson. Welcome to the Clinical Trials and Evidence Synthesis Seminar. We're really lucky this morning that we have Dr. Janet Wittes as our speaker, and she'll be talking about a recent paper from this summer in clinical trials. So thank you all for coming. I'll give you a little bit of background about Dr. Wittes, Janet Wittes. And the thing is, she has so many accomplishments and honors. So I could just, it's a whole page, and I'm sure it's shortened that I could read to you. And I have to be honest, I know all those honors, but I really respect her for her brain and other things too. But anyway, I'll tell you the honors. A little bit. So she has a business in Washington, D.C. called Statistics Collaborative. And she founded this Statistics Collaborative in 1990. And but she's also a fellow of the American Statistical Society, the Society for Clinical Trials, and the AAAS, the American Association for the Advancement of Science. She has all sorts of honors from these groups. She's a statistician by training. She got her bachelor's degree in mathematics from Harvard and her master's and PhD in statistics from Harvard as well. So she certainly is trained. And she's been working for a long time. We all follow her and have for years in terms of her thoughts about statistical handling of clinical trials, especially intention to treat analysis, and she'll talk about that, I'm sure, this morning. She was an editor of the journal that was called then Controlled Clinical Trials and now is called Clinical Trials. She's written books, and I have to say one of my favorites is related to data monitoring, and I love to hear her talk about examples of data monitoring because they make it really real. The case studies, it's just fantastic to hear those. So I also want to mention, as a role model, she has 3 kids and 4 grandchildren, and she did all this while getting her PhD. She tells me that when she was teaching at Hunter College, she used to bring her son to class, and he would ride up and down in a fire engine in the hall. So she did it all and is a wonderful role model for all of us. So without further ado, let me hand it over to Janet Turk Wittes, who I found out is the sister of someone who's a friend of mine in college, just because she started using her maiden name.
So before you go down, notice this. It turns out that we both have necklaces from the same artist, and we both wore it today. So thank you so much for inviting me, and thank you so much for being here, everybody. And I do have to say that the reason I now put, when you have 2 names, one when you were born with and one that you were married with, I didn't, for many years, I didn't use the Turk part. And then one year I did. And Taddy came up to me and said, "Are you related to Dan Turk?" I said, "Yeah, that's my brother." So after that, I've used it all the time, thinking maybe other people might know one of my brothers. So what I'm not going to talk about, in the great tradition of our newly elected president, I'm not going to do what I say I'm going to do and hope that our newly elected president will not do what he says he's going to do. Instead, I take this as a jumping off point. Part of the reason I don't want to talk specifically a lot about what I said I was going to talk about is that some of the people who really know much more about the 2 topics, CDP and per protocol effects, are, where are you? I can't find you. Where? There you are, there. Liz. Oh, right here. And so it's better if they talk, but this will be a jumping off point. So let me, see if I can help. There. Okay. So here's what I'd like to talk about. First of all, what we learned from Paul Kanner's analysis of the CDP. I want to talk a little bit about what is the I know you all know it, but I just want to get us on the same page. ITT as randomized, per protocol, as treated, completed, those kinds of analyses. Whoops. I'm not very good at things like this. There it is. What Murray and Hernan said in their published paper, I'm not going to do a lot about their paper or my discussion about it, because it's easier if you just read it yourselves. But I do want to talk about the principled nature of ITT, that it's not a charade. And we randomize not because we're following somebody's rules, but because we believe what we're saying. And then a little bit about the importance of causal inference, which is where the Murray and Hernan paper is coming from, and how should we intend to treat people use it. And then most of my talk is going to be about as-treated analyses for safety, and I'm going to take what's considered a radical view that actually I don't think that's the right analysis even there. And then maybe I'll summarize. Okay, so what did we learn from Paul Kanner's analysis of the CDP? As those of you who are young enough, or maybe movie buff enough to have seen, if you remember the wonderful, in Annie Hall, they're standing in line in the Murray Beekman Theater in New York, which is no longer there. They took it down, and it's now Memorial Hospital. And Woody Allen is standing in line and fighting with the person in back of him who's pompously talking about Marshall McLuhan. And Woody Allen says, "You don't know anything about Marshall." And they're fighting back and forth. And Woody Allen says, "Well, I happen to have Marshall McLuhan right here." And he pulls the curtain back and he brings Marshall McLuhan in. And then he stands up. He steps out of the movie and he stands up and he says, "I wish life were like that." Well, here, I happen to have Paul Kanner right here. Life is like that. And he will tell you about the CDP. Oops. If I can figure out how to. Okay. Thank you. Our very own Marshall McLuhan.
Okay, Coronary Drug Project, prospective clinical trial to evaluate the efficacy of lipid-influencing drugs in the long-term therapy of coronary heart disease. This included random allocation to treatment, placebo-controlled, double-blind evaluation of treatments, 53 clinical centers with a common protocol, 5 to 8 year follow-up of patients. One slide that I forgot was, when did this happen? Actually, we just had the 50th anniversary of the randomization of the first patient to the CDP in March 1966. There were 6 treatment groups, and the one that we're going to focus on this morning for a few minutes is clofibrate, or Atramid-S. This was a relative newcomer when the study was first being designed back in 1963, 62, 63. Clofibrate, nobody knew anything about clofibrate. But then there started being reports about clofibrate and its cholesterol-lowering effects. And so it was added to the study, and it turns out to be rather the darling of the Coronary Drug Project investigators. I think the general consensus before the study started and during the study, if any of these drugs is going to turn out to be good for patients, it's going to be clofibrate. These were patients, these were males, 30 to 64, YNO females. Back in the 1960s, females did not get coronary heart disease, right? ECG documented MI, and the rest. Okay, about 8 years later, actually 1975, the study treatment phase came to an end. And here are the results for clofibrate. 20% mortality for clofibrate, 20.9 for placebo. Not much going on there. And this is 5-year mortality. Remember in the previous slide, these patients were followed for 5 to 8 years. And so if you look at all mortality, all of the patients, whether 5 years or 8 years, mush them all together, the result is even closer, 25.4 to 25.5. And when we presented these results to the study investigators, they were very disappointed. And they asked lots of questions. Can we tease out some kind of beneficial effect from all these data? Well, how about the good adherers? How about the patients who had a cholesterol response to the drug? And our fearless leader, Jeremiah Stamler, stood firm on that. He said, it's an invalid analysis. There's no control group that's comparable when you start looking at post-randomization variables such as adherence or cholesterol change, etc. And so the investigator group grumbled a bit and murmured, but they finally accepted that. Well, when we got home from the meeting, the chief statistician of the Coronary Drug Project thought, well, I wonder how those data do look. And so he did an analysis and with the following results. For clofibrate, those with 80% adherence or greater, 15% mortality. Those with lower adherence, 24.6% mortality. Wow. That's very interesting. But what about, we still don't have a control group here. Well, let's look at the best control group we have, namely placebo. And 15 versus 28.2%. And then if you look across, I don't know, is this a pointer?
Yeah, at the top where it says green, it's green.
For those with good adherence, the investigators wanted to look at that. There's no difference between drug and placebo. And if you want to find a difference, we'll look at the poor adherers, those randomized to clofibrate who didn't take their drug faithfully. But these are just very difficult, as Dr. Stamler rightly said, we don't have a proper control group. And we tried adjusting for some 40 baseline variables, and it brought the difference down a little bit to Z value of 5.94. But that's it.
Thanks so much, Paul. So, and it's funny because I interviewed Jerry Stamler a few years ago in his apartment in Riverside Drive overlooking New Jersey. And he made me nuts unsalted, that he roasted, and he talked about how excited he was when Paul came in with these numbers. Anyhow, so now let's jump back to what kinds of analyses do we do in clinical trials? So we do ITT analysis, intention to treat, or also known as randomized. How did you randomize? And therefore, you've got the balance of randomization. Then there's something, I don't know whether you guys use this, but in industry trials, they use something called MITT, which they call modified ITT, which I think of as DITT, distorted ITT. It's modified by including only, so you randomize, and these are usually for trials where the outcome is some continuous measure. But not always, that you randomize, and then you take those only who've used some study drug already. That's a post-randomization event. And then you only take those who've had one measure past baseline, because how can you know what's happening if you don't have a measure past baseline? That's what's called modified intent to treat. And much to my horror, when I started working with industry and FDA, I realized this is kind of the standard method that people use. Okay, so to me, it's a through the looking glass kind of analysis. And if you remember, Alice goes, she sees Humpty Dumpty. She says, I don't know what you mean by glory, because Humpty Dumpty has just said a sentence that she didn't understand. And Humpty Dumpty smiled contemptuously. Of course you don't, till I tell you. I meant, there's a nice knockdown argument for you. But glory doesn't mean a nice knockdown argument, Alice objected. When I use a word, Humpty Dumpty said in a rather scornful tone, it means just what I choose it to mean, neither more nor less. The question is, said Alice, whether you can make words mean so many different things. And Humpty Dumpty says, again, as our new leader will be saying, the question is, said Humpty Dumpty, which is to be master? That's all. To me, that's the MITT. You stick the M in front of it and you give it fake validity. So then there's the per protocol analyses, or as treated. And again, there's a lot of different definitions of them. It's only those who follow the protocol. Well, what's the protocol? I mean, is it that did they come in exactly on time? Did they do everything exactly right? Did they do some things exactly right? What is the definition of per protocol? It usually includes satisfies the entry criteria. Maybe not exactly the entry criteria, but pretty much the entry criteria. And it took people who took treatment in the way the protocol said they were to take the treatment. Again, maybe not exactly, if you could be off for a pill or two or off by but pretty much that's kind of per protocol analysis. And it is clinically attractive for many of the reasons that Paul's investigators said. Why should a drug work if you don't take it? And what the docs will say is, I want to know whether my patients will get better or improve or whatever if they take the drug. I'm not interested in knowing what's going to happen if they don't take the drug. And as a patient, one would like to know, well, if I don't care about these non-adherers because I'm an adherer, I want to know what adherers do. So it is clinically attractive. Of course, as a statistician, I get really upset about the what's called clinically important, what's called scientifically important, but nonetheless, it really is an important question. And we know that there are with methods of clinical trials where you can do randomized withdrawal. You give people a drug and then you randomize to drug and off drug and you see what happens. So you get rid of this. You can actually look at what's happened to people who have the propensity to adhere. They've shown their adherence before the study and then you randomize. Now, what did Murray and Hernan, who's supposed to have an accent, and I left it off there. And this is a paper. You really should read it. It is very interesting. I really wish you guys could read the early versions of it, but that's not what's published. What they say is don't use naive per protocol analysis. And that clearly is right. Don't just do what lots of studies do, which just take this group of people who have adhered or followed the protocol and analyze. Don't do that. But use methods that avoid the bias inherently attendant on post-randomization subgroups. And there, Liz can talk about that much better than I can, and that's why I didn't want to talk about this in the details, because the methodology is complicated and sophisticated, and one has to be very careful. It comes from a long history. Heckman won the 79 Nobel Prize in Economics for studies of selection bias in observational studies. And basically, that's what we're talking about. Adherence analysis is basically, or analysis based on post-randomization variables are basically selection bias. And then there are causal models with different different schools of thought. And then what Murray and Hernan say is, well, why don't we do adherence-based analysis? And there's the person they blame. It's Paul's fault. Because he wrote this paper that everybody uses that's how you learn about the importance of ITT, and that's how generations of people are taught in school, and that's the paper that is used. And that's the model, that's the lesson. And they say, well, it wasn't quite 50 years later, it was more like 40 years later after the paper. We're going to redo the analysis. And we're going to redo it because we have different statistical methods now. We can, we'll use statistical methods that weren't available in the 70s. We'll redefine time intervals because, again, it's very hard when you talk about who's adhering. What do you mean by adherence? Again, so that's my sort of, is it all the time? Is it some of the time? Is it most of the time? Or do you take drug holidays? Is it adhere and then you stop? It's very hard to define adherence. So they have a bunch of different ways of defining when people are on and when they're off. And then they use causal models. And they do many sensitivity analysis. That's in the, on the online part. So many. And they conclude that the difference that they get between adherers and non-adherers in the placebo and the clofibrate group is not as large, is much smaller than Paul's. And therefore they conclude, and now I don't remember whether it's in this paper, you know how sometimes your brain can't separate what you once read from what is there now. But I don't remember how much they're blaming you. But basically the message is, if it weren't for that paper, people wouldn't be so convinced about the importance, about the problems with adherence analysis. And that paper, if it had been written a few decades later, would have used other methods, and the difference wouldn't have been so big. And what is so impressive about that paper is the big difference. Well, what is so impressive about that paper is not the big difference. I mean, that is what grabs you. But my own view is that had that paper not been written, had there been some other example, if Paul had done that and hadn't found such a big difference, then I'm sure Jerry Stamler still would have, because he understood that there weren't controls, there would have been some other example that would have found that. So what should we do in the light of what we know about causal models now, what we know about the dangers of post-randomization subgroups? I think we need to, and what we know about the importance, the clinical importance to doctors and patients about how do people do if they actually take a drug? I think we need to start thinking seriously about dealing with compliance and non-compliance in ways that the causal analysis people are telling us. But we have to be careful. And we have to recognize that these are quite model dependent. And I think what we have to do collectively as a community is try them out. And it's be very hard to publish when you publish something in a medical journal. You have your 4,000 words or your 2,500 words, depending what the journal is. And it's very hard to say, here's the primary analysis. And we also did this as a way of exploration, and here's the models that we use. Very often not enough space. But I think we need to be starting to do that collectively so that we can get, as a community, collective experience. But, and now here's my big but, I don't know what pronouns to use. I am afraid of as treated safety analyses, and I hope you will be too. So what is causation? And again, just as it's very difficult to talk about what is adherence, it's difficult to talk about causation. There's all kinds of causations. But what kind of causation do clinical trials address? They address the question, what we want to ask is, did the action of the drug that we're studying, or the action of the intervention, whatever it is, did that lead to the event? But it doesn't ask that experimentally. It asks, did assignment to the drug lead to the event? And that's a really important distinction, which I think lots of people, certainly in the real world, don't distinguish between. And so here's an example that I'm sure all of you, the type of example that all of you are familiar with, but you're going to, for those of you who are students, you're going to be confronted with this kind of thing for the rest of your lives, because it's very much like the compliance thing. This is an example of survival of responders to non-responders. Okay, and this is what they used to do in cancer a lot, and they still do it somewhat. My husband, who's an oncologist, when he was a fellow, he came back and he came home and he said to me, "You're not going to believe the kind of analyses these people do." So what happens? So you take people who, you give them some chemotherapy, and you separate those who respond to the chemotherapy, i.e. their tumor reduces, and those who don't respond. And then you compare their survival to the responders versus the non-responders. And guess what? On average, the responders live longer because they had to live long enough to respond. All right? And this is in a journal article. And this is, oh dear, I'm not fair, because this article is an article about why this is wrong. Okay, it's not an article saying it. And then Rich Simon and my husband wrote a paper about it to argue you should never do this. And of course, in oncology, they still do it. Here's an example of the VA trial on bypass surgery, medical versus surgical intervention. And this was, so the idea was you randomize people to bypass surgery, or to medical treatment, and you looked at, this is the 14-year survival, and there's no difference. So people said, well, let's consider those who adhere versus not adhere. Well, what does adhere mean? In the medical people, not adhering is not taking your drugs. In the surgical ones, not adhering is not going to surgery. Well, guess who they are? They're the ones that the surgeon says, you are so sick, I'm not going to operate on you. So who's left? The people who are strong enough to have gone through surgery. And guess what? They live longer than the medical people. The other analysis that people do is what's called treatment received. All right? You put people in the group to the treatment that they got. So what does that mean? That means that everybody in the surgery group who didn't get surgery goes down to the medical group. And everybody in the medical group who later on gets surgery gets up to the surgery group. Well, obviously that's a little bit like our previous cancer example, because in order to get surgery, if you're in the medical group, you had to have lived a little long. So the curves even get farther apart. Okay. So what about safety? So I think those examples are all efficacy examples. I think we all know in this room, we all know why these are wrong, and it's appalling, but okay, fine. We need to have these examples so that when we work with people who don't understand them, we can say, look, here's CDP, here's this one, here's that one. This is why you can't do these analyses. Well, what about safety? What you'll hear in safety is that if a person doesn't take the drug couldn't have caused the adverse event that was experienced. And therefore, safety analyses should be based on as-treated analyses. Okay, you guys with me? All right, now we're going to another step. And furthermore, if you stop taking the drug, you should be removed from the safety analysis because you don't have the drug anymore. So therefore, it can't have caused a problem. All right. So if you believe that, just suspend your disbelief for a little bit, and I'm going to try to argue that you really should be using ITT even in this case, and I'm going to argue a little stronger than I believe. So, again, what are we thinking about when we're thinking about cause? We're thinking about final cause. What is it that this drug is doing that may or may not be causing this adverse event? And the reason that people argue for on-treatment analysis goes like this. And I cannot tell you how often I've heard this. And I don't know whether this happens in the settings that you guys are in. It does. Okay. It happens in a lot of the analyses that I'm involved in, which are a lot of drug company and FDA. FDA believes in this too. Here's the argument. The drug is gone from the body after about 5 half-lives. So once it's gone, it can't cause an event if it's not there. And therefore, safety analyses that you will see in labels of drug often have removed from the follow-up time anything that happened more than 5 half-lives after the last taking of the drug. So what's the problem? Well, first of all, is that it doesn't reflect the experiment. That may not be a convincing argument. Second, it ignores the reason for going off. Maybe the person went off study drug because the person was sick. Maybe the drug caused something that led, so then they go off, and then something worse happens. And in efficacy analysis, we do ITT analysis. We say we respect the randomization. We know an event can cause a cascade of events, and we're interested in that cascade. So if you look at lipid-altering drugs or diet, we say that a change in lipids can have a long-term effect, even if the patient goes off the drug or relapses from the diet. And Mr. Fitz showed us that many years ago. So you reduce your LDL, you stop taking your drug, but your long-term probability of heart attack is lower than those people who didn't ever lower their LDLs. And my question is, and this is where I'm a little stronger than I actually believe, why don't we think of safety in the same way? So let's go some examples from life. Why don't we think that cancers that came later weren't due to the late effects of radiation? We don't say, oh, that's so long ago, these cancers don't count. Of course we count. Smoking. Why don't we say that for lung cancer, we don't count those lung cancers that occur after people stop smoking, because they've stopped smoking. Well, what we know is the damage to the lung was done. You stop smoking, the lung doesn't get better, and bad things happen afterwards. Heart disease is a little different. So now this is where I'm disagreeing with myself. It's really important
to think about the closeness of the biology, right? Because in smoking, there really is a difference between what happens to the lung and the relationship of lung cancer to smoking and ex-smoking, and what happens to heart attacks and stroke, the immediacy of the going off. Example 3, the coxibs. So I think a lot of you know that rofecoxib, or Vioxx, when the studies were done to prevent adenomas, what Merck did was to look at adverse events, serious adverse events that occurred within 14 days of going off Vioxx, right? Because that's more than 5 half-lives. After 14 days, doesn't matter. But when they looked longer, there was a whole lot of, because the celecoxib people went 30 days, and we did the analysis of celecoxib. We did to the end of the study, and the longer you went, the worse the results were. If you looked longer, what happened, the harm was bigger, and especially things like heart failure. The explanation being probably that people who were getting sick in one way or another, having symptoms of something, their docs would say, just get off your experimental drugs. And then the adverse events started coming in. So I want to give you an example from the Saxagliptin study. This is all-cause mortality. So Saxagliptin is a drug for type 2 diabetes, and the primary endpoint in these studies were hemoglobin A1C. But the FDA reasonably, and everybody wanted to see, if you're on these drugs for a long time, what happens to mortality. And if you looked at the on-study deaths, now these are not quite intent to treat. This is the people who, the way this study worked is you were on the study, and if you went off, you're randomized to Saxagliptin or placebo. If you went off your drug, you were supposed to stay on the study, but if you didn't, you didn't. All right, that was the design. So the on studies are those who didn't stop being in the study, whether they were on or off their drug. And what you see is a small increase in hazard ratio in the Saxagliptin group. All right, 10% increase in hazard ratio, not significant, but it raises the question, is there an increase in mortality? So what the FDA said, this is the FDA's analysis. Well, you can't go out to the end of the study. Only look at the people on treatment plus 30 days after that. And look at that. Whoa. My other brother says that when he gives a talk. Whoa. The brother you don't know. Well, anyhow, the 1.18, okay? So if you look at 30 days afterwards, the hazard ratio goes up. And if you go to 7 days, right? So I'm going to only look at the deaths from the time of randomization to 7 days going off study drug. The hazard ratio goes to 1.23, statistically significant increase in mortality, and therefore this is a dangerous drug. Okay, so let's look at in the placebo group. Now this is so even if that CDP analysis would have been done differently, now because we have different methods, this is a Paul Kanner type analysis. All right, so I've learned from Paul how to look at these kinds of questions, even though it's in a different setting. So look at the mortality rate on treatment. These are smooth mortality rates over time, study months. I mean, so basically what you see is a very low mortality rate for people who stayed on their placebo or who were on placebo while they were on placebo. If you say, well, what about those who were randomized to placebo but went off placebo? What's their mortality rate? Well, it's about 10 times higher. So what do you have to believe that this is meaningful? You have to believe that this was an active treatment, right? That this placebo was doing something, or you have to believe something about selection was going on. So let's look now at, But if you look at Saxagliptin, now we see the same thing. The Saxagliptin people on treatment had very low event rates, and the Saxagliptin people off treatment had very high event rates. So if they're the same, why does this happen? Why does the hazard ratio go up when you cut it off early? Well, turns out more placebo people went off study drug. And so therefore, more of the deaths in placebo were excluded from the on-treatment analysis because they were no longer being followed. And so this has caused a huge problem, because everybody believes FDA analysis, right? So the message here in the label and everything is this is a really bad drug because it causes death, an increase of 25% death. So the moral to me is people may be removed from treatment because of illness in a clinical trial. I mean, that's a typical thing. You're on a trial, you're getting sick. The doc says, I don't know what all these experimental drugs are. Get off your trials. They may have a serious event because of a cascade of events. Again, think of the atom bomb. Think of coxibs. Think of smoking and lung cancer. So we need to be doing intent to treat here, or sophisticated, careful causal models that understand the mechanism by which people are getting off. But, and here's the part of me that's the but, in the long run, we're all dead, right? So it's important if you do a survival analysis over a very long time, what happens in the survival curves? They come together by definition, right? So, and because of the mechanism of action and the interaction between what the biology is saying and what the drug is doing, you have to be really careful. And smoking, to me, is a very good example of that, the difference between how you think about lung cancer and how you think about heart disease. And finally, I use this as much as I can now. Before Dave died, he sent me a chapter of a book that he was writing. And he wrote, per protocol analyses, confined to compliant patients are inherently invalid, and I consider them nefarious when carried out by folks who know better. And so now I just want to make another, a little modification to that. Nefarious if they are done the way most per protocol analyses are done, without thinking about how to incorporate the causal models in an intelligent way. Not nefarious if those are done, but those had better be done carefully. And as I said before, with a lot of collective knowledge from us as a clinical trials community to know when they work, how, and why. Thank you. Are there questions? Liz.
So as a statistician in the room, partly your talk was a little disturbing to me because I sort of thought, well, gosh, as people who think a lot about selection bias and confounding, isn't this obvious, and how sad is it that you have these repeated conversations where the statistical literature has known for years and years and years, and there are methods that exist. They have assumptions. They aren't like perfect, but anyway. So my question, so partly I'm sitting here kind of bothered, but anyway, my question is, what can I say as a statistician, or we as a research community do you think, to sort of help move these messages kind of out? you know, beyond those sort of one-on-one conversations with collaborators and stuff, is there any, what do you see as kind of that missing connection?
Well, I think it would be really good to be publishing examples in the medical literature that show what these models do. And they need to be, I don't know, well, and you need to write them in a non-confrontational way. One of the problems that I've seen in some of these papers, and especially in early versions of some of these papers, is that they're confrontational, and that they attack. And the reason I brought up the safety stuff is that that's where I've seen the most mean, I wouldn't say, attacks on the ITT kind of analysis. Calling people who do it stupid, or I once read evil, that I think there's got to be a mutual respect for what we're all trying to do, which is getting answers that are clinically relevant and not too biased. And I think that's why I'm saying that I think it's really important that that we think of this as a community of people trying to figure out what to do and how, rather than I have my methods, and we're going to fight. Is that okay? Yes.
Yeah, great talk. I want to bring up an area that you didn't really cover, but something that I deal all the time with, which is some lifestyle interventions in clinical trials, where, and I'll deal with, a very common issue, weight loss, okay? When we do a clinical trial of weight loss, and let's say the outcome is myocardial infarction, which was what the Look-Ahead study did, we do the trial, but we know from the start that there's massive crossover. You know, you have people assigned to the control group who lose weight, and people assigned to the active intervention group who gain weight. So it's very different from pill-based interventions, where at least you get, you know, I think, an experimental contrast. So the clinical trial side of me, the purist, said never do the per protocol analysis. But the people who are trying to, you know, the reason they did the study was not to test, does assignment to weight loss lead to a benefit? It's, does weight loss lead to a benefit? And so there's this, you know, part of me that says, I really want to address that weight loss issue. Should there be, especially in trials where you expect this kind of crossover, some sort of framework for conducting per protocol analysis that, you know, deal with causal inferences?
Yeah, I mean, I think that's exactly where the Murray-Hernan paper is going, although that's not how they do it. I think it's actually the sort of thing, Liz, you've been saying. But it's so, yes, I think those are exactly the situations, but it's really important not to just take those who adhered to diet and those who didn't and compare them. That there's got to be very model-based. You got to really understand what those models are doing. You got to really play around with other assumptions. So yes, I'm answering yes. If you ask me then, how would you do it? The answer is I would go to somebody like Liz. I don't. But yeah, I think because otherwise we're not getting at that second question. You know, the first question is what did the I'm sorry, not getting the first question. We're getting the second one. What does assignment do? Not getting at that first. Yes.
Professor in epidemiology. So wondering what you thought about using these methods, if you find that they're actually useful, what the implications are for the design of clinical trials, in particular measuring actual predictors of adherence. And that's been one of the frustrating things in observational studies we have found is a lot of times there's this subtle, unmeasurable dimension of adherence that, you know, affects other things that we can't really capture. So being able to fully adjust for the selection biases sometimes not possible. So I was wondering what your thoughts are about the design of clinical trials to actually capture measures of what should be measured, and maybe more research is needed in that area.
So I think that's sort of maybe if I'm interpreting right, it's kind of a two-part question. One is, how do you design the study, and maybe I'm misinterpreting, but how do you design a study that has enough power to take care of that? And the other is, what kinds of variables should you be collecting so as to do the kinds of corrections that would be necessary, that would be useful in causal? Is that's all right? So I think the first question is relatively easy to answer, because from an ITT point of view, you just figure out what you think the crossover will be, and you attenuate the effect, and you increase your sample size. The grant may not like that because it may be a big effect, but you can get your ITT analysis that way, and you can figure that out. What variables should you be collecting in order to do the kinds of selection bias analyses that we're talking about? I'm going to cop out and say I don't know. I mean, that's got to depend on what the study is, what the population is. So I'm answering it depends on them.
But it was also more of a sort of something for us to think about, in that I'm not sure, a lot of times these methods are applied long after the trial is completed, and so we're using the variables that are there in the data, and they're not really thought about a priori. So there could be opportunity at the design stage.
Yeah, Liz.
I want to echo that. Actually, I'll say it in a slightly different way. I think often people are used to trials and used to the intent to treat effect, and used to thinking, oh, we don't really need any covariates. Like the randomization gives us balance, and so we're good. But I think once you start moving into any of these analyses, they are inherently non-experimental. Even if I loved your use of a term, even if you call it by something else, it is still fundamentally non-experimental. And so then it sort of raises these questions of, so maybe we need to be more thoughtful than we traditionally have been in trials to think about what are the covariates that we need to measure to make the assumptions more tenable. So I think, and again, I think it's a mindset shift in some ways, because we're used to thinking in a trial, we don't have to adjust for covariates, we don't have to measure covariates. But again, for these analyses, it can be really useful.
Well, and I guess there's analyses that actually there's what baseline do you collect, and then what you collect along the way. And does collecting along the way affect the results of the experiment itself? I mean, right? You're
thinking baseline only.
Baseline, okay, that's easier. Baseline only, yeah. But I think it would be important, and I'm saying this as somebody who does not know how to do these analyses, to involve people like Liz in thinking about that, because people like me, I would not know what covariates are we talking about, and we don't want to end up with 50 million covariates that most of which aren't needed. So that's another area where I think real communication between these communities could help a lot. Yes.
I'm the clinician.
Okay.
Janet, is there any difference in your approach to using the ITT population, whether it's non-inferiority analysis of safety versus superiority or inferiority?
Oh, I don't know. Have you read my Alice in Wonderland paper on a non-inferiority? It's a Through the Looking Glass paper. I have lots of trouble with non-inferiority, and so the glib answer. I can give you a glib answer.
Yeah, that's all I need.
No.
I'm the clinician.
Yeah, the glib answer is you do an ITT analysis, you do a per protocol analysis, and if they're the same, you're fine. Yeah. But of course, unless your trial has been done really carefully and everybody coheres and they won't be the same. So that's not a very good. And also, typically, the per protocol analyses that the non-inferiority people are talking about are exactly the per-protocol analyses that we should be worried about, because they're the per-protocol analyses that aren't adjusting for anything. So again, the quick answer, a little less glib, is I think it's actually very hard. And while the piece of me wants to say, if you're going to do a non-inferiority trial, you better make sure everybody adheres. Well, that's not really smart either, because part of what you're studying is whether people can stay on these drugs or not. So sorry that's not a very good answer, but or the other approach is just don't do non-inferiority trials. That's another. Yeah, Kay.
So I have actually a comment and a question. The comment was just thinking about the Women's Health Initiative, which you know very well. And there, I think people tried to measure the covariates at the beginning, but then when you look at the results of the trial and compare it to the results of observational studies, which I think is natural, you want to know why you came up with different answers. There probably were some unmeasured things that to this day we don't even know. We can just guess why the results are different. So that's a comment. You know much better than I do about that. But then the question is, in your example about safety analyses and why you can't throw out the people who fail to adhere, I had the sense you were talking about adherence that changed as the study was going on, not, say, in a surgical trial, people who never had the surgery. So I'd be interested in what you had to say there.
Yeah, I wasn't talking about surgical trials. You're right. I was talking about trials where where you're taking drugs continuously. In terms of the Women's Health Initiative, so I'm going to make a confession about how we actually, so I chaired the DSMB for that trial. And you can imagine that, here that trial was being done because in observational trials, the reduction in heart disease was 50%. People who were on hormones therapy, then called hormone replacement therapy, their heart attack rate was reduced by 50%. And then when the PEPI trial was done, and I was on the DSMB for the PEPI trial, that looked to see, do hormones actually affect the surrogates? And yes, they did. They lowered blood pressure, they increased HDL, they did all the right things. So the trial was, some of us thought it wasn't really necessary because we knew the answer, and the first job of the DSMB was to answer a criticism from the IOM that said this was an unnecessary expense because everybody knew what the answer was. And we, the DSMB, sat around and we said, the experiment has to be done because we don't know the answer because the experiment hasn't been done. But each one of us internally believed that we knew the answer, but we felt, rigorously we had to say that. And then when the data started coming in, and we saw this increase in heart attacks and the big increase in strokes, and what we all did, again, violating all our principles, is dividing by the number of people who were not adhering, because about 50% didn't adhere. And that, of course, doubled the race. So we were really scared. And sitting on that trial, watching the data come in, and having to make a decision, we have to keep on going because nobody will believe us. It's too early to stop this trial. Was really, really scary. So, okay, thank you all for coming. It's always nice to be here.
Thank you.